Thank you, Bernie. And a lot to live up to, right? So thank you, everybody, for being here, and thank you for having me moderate this panel. I'm delighted. We were just having a brief little meeting just before we came in, and I could hardly hold my excitement, as they all noted. So I'll do my best to keep that in check. We're very, very lucky to have 3 people here today who are patients, caregivers, and advocates, and they've generously, agreed to share their experiences with us and offer their benefits and insights around communicating about medications. We know how very important that is. I will ask the panelists some questions just to really get the conversation going, but it's largely unstructured, so who knows where we may go, and that's, I think, the fun of this. So as Dr. Rossoff mentioned, please hold your questions till after the panel, and then we will take them starting with Roundtable members first. So I'm going to start just by introducing the panelists. First, we have Darvece Monson. Darvece is a nurse and an advocate. In 2015, she founded More Than Your Kidneys after being diagnosed with chronic kidney disease. She is now a kidney transplant candidate. Darvece has participated in clinical forums and patient advocacy panels, and she has worked with the National Kidney Foundation and is a certified kidney educator through the American Kidney Fund. We also have Bobbie Reed with us today. Bobbie is the mother and a caregiver of a kidney transplant recipient. When her son was diagnosed with end-stage renal disease in 2013, Bobbie took on the task of coordinating his care through hemodialysis and eventually a kidney transplant. She's very active with the Kidney Health Initiative and is the Pennsylvania Kidney Advocacy Committee liaison for the National Kidney Foundation. And last but not least is Caleb Sexton. Caleb is a designer focused on health literacy technology research and how human-centered design can really provide opportunities to facilitate better care and communication between patients and their care providers. He's an advocate for people with psoriatic disease and works with the National Psoriasis Foundation to do outreach and education. And that's just a very brief description because of the limit in time. Those of you that have a workbook on, I think it was page 25, there's an extensive patient experience write-up about each of our panelists. So if you'd like to take a look at that, it'll just give you some more insight. So I thought today, welcome, thank you for being here. I thought today the first question, maybe just to get the conversation going, would be what are 1 or 2 lessons learned or experiences or light bulb moments that you could share with us and the audience? And we did speak about the fact that we have clinicians and researchers and advocates and policymakers in the room. So what would 1 or 2 light bulb moments or key messages that you would share regarding your overall experience about medication communication, whether it be oral communication or written communication? Would anybody like? Bobbie, you want to start?
Okay, I'll start. I think in terms of medication, it was very difficult because everything happened with us so suddenly. Management of the medications, the multiple medications that had to be taken, not one person could do this on their own. So I took it upon myself to try to understand what was going on and move forward from there. When we were in training for our home hemodialysis, I was with the support person for my son, and the nurse there at the center where we went for our training made available to us a specialty pharmacy unique for dialysis patients. So our medications were managed through there, which was really nice. They'd deliver them right to the door. She would give us our schedule of what the different medications were and when they were to be taken, and that worked out quite well. However, since my son got his transplant, it's been 1 year, November 9th, we no longer have access to that specialty pharmacy. And very quickly I learned that I was at the pharmacy every single day, it seemed, picking up this medication or that medication to manage things. I soon found or discovered that our pharmacy offered a specialty pharmacy service which afforded us free of charge a nurse case manager and a customer service person. 24/7, we had availability and access to this, whereby they would coordinate all the medications needed, transmit that information to the pharmacy, and we would only have to go at most maybe one time or twice a month to pick up the medications needed. To take that further, I developed, to help manage it a little easier, a list of all the medications that he had to take at various times of the day. The day we left the hospital, in fact, the nurses there gave us a sheet saying, you're on these medications, this is when they're to be taken. However, I took that a step further and developed on the end of that, my own spreadsheet, pills on hand or medication on hand. And monthly, to let the nurse case manager know about this at the specialty pharmacy, all we have to do is fax it to her or call her up. And that served two purposes. One, it let them know, as well as the doctors know, that he was adhering to taking his medications when he was supposed to, because that pill count wouldn't be going down if he wasn't doing that. And secondly, it indicated to them when they needed to put another order in or when to schedule that particular medication to be refilled, or in many cases they do this for us too, they contacted the doctors or the transplant center clinic directly and made arrangements for those refills, taking that burden off of me, the caregiver, or my son, the patient. So that was very, very crucial in that regard. That has tremendously helped me, and I strongly suggest somehow with patients going forward some sort of a format like that that could be adopted. When I took that back to the specialty pharmacy, they said they didn't have anything like that, and this was an ingenious idea, and they adopted it as part of their protocol, so that if his coordinator, nurse manager wasn't there a particular day, very easily that information was accessible to whoever might be filling in. And it served a big void, but it does not take the responsibility off the patient, because you still have the patient having to be accountable for what they're doing, but it also made managing the process much, much easier.
Thank you for that. So a case manager, coordinated approach, a continuity of care, communication, all those things, pulled together seem to help tremendously.
Yes, it did, and the specialty pharmacy concept is great. I think it's something needed to be explored. I just happened to fall upon it one day when I was at this grocery store, and I saw a sign, "Did you know about our specialty pharmacy services?" And I thought, I wonder what that was.
That's great. Maybe
and I'm sure a lot of people don't know.
We could talk a little bit more about that later. Caleb, did you?
First, thank you all for being able to be here. Kind of building off what Bobbie was talking about, the specialty pharmacy. Since now being on the 10 years of the other side of being diagnosed with psoriasis, an autoimmune disease, everyone thinks about it with the skin, but it's so much bigger than that. I remember when I was 19 and I was first diagnosed that I was put on all the step therapies and biologics simultaneously, and there was no real communication about what this disease was to me. There was no real communication about what it meant or what it could mean. We typically think of certain autoimmune diseases, speaking specific to psoriasis, around things that it's like a skin disease, but it has so many other factors, all sorts of comorbidities. And if there's never any context or being able to take a minute to really, talk about what this means is a life-changing situation, even building off of the kidney transplant situation, that is a life-changing experience. And being able to provide patients with a better foundation of understanding and how to communicate about that, and thinking that, it's not just what I tell you here in the office today, but here's a list of resources. There's an ecosystem that is out there for your support, for your journey, because this isn't something that is a one-and-done situation. It is something that's going to be with you for the rest of your life. And, being, again, 10 years on the other side of that, being able to say, if I were to go back and talk to new patients, new diagnosed patients, and that's what I try to do with NPF, is, we're here for you. There are people here to support. There are social networks that you can become involved with that better understand and can better communicate with you, because it's terrifying. You're put on systemic chemo drugs, you're put on biologics, you're put on creams and other pills, UV therapy, and no one knows what that means. And no one knows, or is told, like, okay, by combining these different things, you're going to have some really nasty side effects. This is going to be something you're going to actually have to endure to get better. But there's no cure.
touching on, good morning, first of all. Thank you for allowing me to be here. Touching on what the both of them said, I agree wholeheartedly. I'm a patient, a hemodialysis patient for 19 months in center, pre-kidney transplant, and I'm also a nurse. I've been a nurse for 20 years. I started very early on in my career. So I'm able to communicate from both sides of the spectrum as a nurse as well as a patient now, which is to my detriment as well as to my benefit in that I'm able to be objective to a point, and I'm in center with patients, and that was not my specialty prior to my diagnosis. So I'm able to see the population that the majority of my diagnosis is comprised of. These are the subject matters in that I'm end-stage renal disease and kidney transplant. And when it comes to the medications, consuming them as well as being required to take them, I witnessed so much from the nurse's standpoint as well as the patients that are required to take them. And so I'm able to say that there needs to be a bigger emphasis in communication in regards to specifically toxicity, adverse reactions, as well as side effects, because the patient population generally does not understand the difference. And as a patient, I have found myself being able to be as successful as I am in my journey, eliminating and the margin for med error significantly, but most of those benefits were because I was a nurse already. So when you, like Caleb said, combine all of these medications, and you have some written literature that explains what a side effect may be very randomly, but not specifically. So these are things that people look for, but at the same time, it's per medication. When I first got diagnosed, I had 14 medications that I was on, and they made me worse. It was a combination of so many different factors. And then I'm a part of a disease process where, contrary to what people believe, there is no one size fits all. But as you can see, I'm 36, I'm young, I'm viable, I'm active, I'm mobile. So the population of renal patients really aren't. They're gerontological, they're immobile, they're not cognitively aware and able to communicate. So I found myself in different situations where my knowledge base and experience put me ahead of the game in that it's 2 or 3 o'clock in the morning. I've been taking 4 hypertensive medications for about 6 weeks now, and I just can't figure out why I'm coughing. Well, I think one day it was like 3:30, and I'm like, oh my gosh, I can't stop this coughing. And the nurse light clicked. Well, I'm coughing because I was on an ACE inhibitor, a calcium channel blocker, so on and so forth. So yeah, that's going to happen. However, someone else in my situation and does not know that, and they don't even know, it wasn't printed on the medication to look for this. Okay, with my procardia, it simply stated, do not take this medication with grapefruit juice, but it did not specifically go into why that's so important. And so before I started my organization, these are the complications that arose within me, and so I started doing some polling in my local dialysis center and asking people if they knew certain things, and a lot of them did not know. I came up with 87% because, again, when you go to the dialysis center, for most people, this is your weekly field trip from the nursing home, from your acute care center, or whatever the case is. It's a specialty, and you're so drained after that. And so these are the reasons that I really wanted to come here to express that, because I'm blessed to be able to communicate that from both standpoints. And it's easy to throw up a screen while in a dialysis center and say, okay, watch this movie, watch this video clip about your binders. But at that time, we have to understand that these people who are mostly older in age and not cognitively impaired and unable to verbalize their needs and understanding, you're white, you're on a machine. So simultaneously watching something that's going to, that's going to actually help you to understand on a certain level is very difficult and in some cases unrealistic. So we have to consider that and find out and come up with better ways to communicate effectively
Thank you.
the detriments.
Thank you. When we had spoken a little bit earlier, we had a brief call. I said, what did it feel like when you wanted to communicate about the medications, or Was it hard? How did it feel? And I jotted down very quickly as each of our panelists spoke, and if it's okay, I just wanted to read the words that you spoke. Intimidated, barriers, overwhelmed, terrifying, confusing, want statistical information to help with risk and benefit, side effects, I felt worse, challenging, hard, discouraging, put off, put back. So that was how it was described. So I found that pretty overwhelming, actually, to hear all of those terms to describe communicating about medications. Not one little glimmer in there that of hope, but we'll change that today. For another question, I was thinking from the clinician side, is there one question or one response or that you wish that your prescribing clinician, whether it be a nurse practitioner or a physician, asked you when prescribing those medications or when changing your medication regime? Is there one question or something that they could have done that would have made it better? Caleb, do you want to?
Yeah, I'll jump first. For me, I think, and I mentioned this in our call earlier, is if I were being asked, what's your biggest fear? And the reason I say that is because just as what Darvece had mentioned about not taking this medication with grapefruit juice, context is king, and understanding the why and the reasoning, and having someone willing to sit down and feel empathetic enough from a care provider's point of view to say, what's your biggest fear about this? I understand that you don't know anything about these medications. You don't know anything about these side effects. We don't even know what's going to happen, but that we're here for you and that we understand the challenges that you're going to face. And we want you to know that we're here to support you, not just while you're here in this room with us, but once you go home. We want you to know that there is a network out there, that there are people that we can support you with, and that we're here for you for whenever we discover or find out that your medication isn't working or it's causing drastic side effects like losing 30 pounds in 2 months, or other conditions of chronic cough. But that we want you to know that we're here to feel empathy for you because we understand that this is a long-term thing that is not going away.
So I think, just if I could jump in, when he mentioned that, my light bulb went off, and I thought I did a pretty good job over the years, always open to learning. And I would ask, what is your typical day like? Do you think you'll be able to do this? Who fills your medications? Are you able to get them? I mean, I would ask many questions, but never did I ask, what is your biggest fear or what is your biggest concern? So I was sharing that I've already learned more and have incorporated, and it's changed my practice. So I thought that was just such an interesting point, and thank you for sharing that with us. Bobbie?
Well, I'd like to give an example of an experience that we had. On the day that we went in for our transplant visit, for pre-surgery visit, the surgeon actually came in and went over our medications that we would probably be, the protocol that we would be put on for, my son would have to use for after transplant. And prior to attending that meeting, I made up a list of questions that I had in the back of my mind, and I looked into different research studies were done on immunosuppressants and what was being done across the broad spectrum. And I came across one particular medication. I don't recall what it was at this time, but I asked him about that. I said, it seems to me that you wouldn't have to take as much of this, and I know that everything has its fallbacks or, side effects, the pros and cons, but could this be something that maybe you would consider doing or looking into? And I was completely shut down by that. He said, no, we have our protocol here that we follow, and this is what we're going to do. And if that doesn't work, then we have another second set of protocol that we follow. That's, something that maybe that they're doing someplace else, but he didn't even want to consider that. And I thought, well, I've done my homework. Why wouldn't he be open to that? And that was sort of discouraging because I'm not like the average person. I was being proactive, and I had some questions, and I didn't feel that they were answered adequately. You know, I got the impression that I'm the doctor, I know what's best for you, and that wasn't what I was looking for. I was looking for, let's look at the big picture here. So I wanted to share that.
Maybe let me look into it, or I don't know, let me look into it
Yeah,
and
that might have
get
been the
back to
better
you.
response. Gee,
Maybe.
that's interesting. Let me check that out, or that's great that you did that, or it was not like that. It was like, I'm the God, and I'm the doctor, you're the patient. Let's move forward from here. And I found that to be pretty discouraging. So I think that needs to be educated or relayed to everybody. You know, if I did my part of it, I would at least expect the same decency or response that they could look into it too.
From my standpoint, if someone could have asked me one question, it would be, especially from a clinician prescribing point of view, as a nurse, I know that each patient has a care plan, a focus of care. So you are this entire person, and our goal is for health promotion and wellness. So that embodies the entire person. So it's my belief that if someone would come to me and say, okay, you know that these are the problems, and we know these are the problems associated with your diagnosis, so on and so forth. So this is what we're going to look for. However, it puts that to the side. What is your problem? What is it that you individually are facing? Because those needs are totally different from the care plan norms, the standard of care, the plan of care, the treatment. I don't have fluid access issues. I'm very strict about my fluid compliance. That's off the table. Potassium, phosphates, calcium, all of these things that medically and according to my diagnosis, these are the things that we're going to check. Never had a fluid issue. So generally speaking, coming from a patient standpoint, what it is that they are looking to me to therapeutically show signs and symptoms of that will show whether or not my disease is processing or digressing, I'm clear of. So what happens with that is that my visit is now cut short. Oh, you're doing good. We'll move on to the next. You have no fluid. Your blood pressure is fine. You're taking your pills, and you move on. But people have to realize that every day in a patient's life, something new is going on. Something is happening that may be new to them. My biggest issue was fecal impaction, secondary to iron, all of the binders that they were prescribing me because this was the norm for my diagnosis. However, they had me taking like 3 phosphate binders per meal or snacks X amount of times a day. Well, again, I'm young, I'm viable, I'm mobile. I eat 6 times a day. And so I had to figure out what was going on with me. And then I'm able to assess myself. I'm seeing abdominal distension. I'm seeing increased gas and flatulence. I'm noticing issues with my breath secondary to what's already going on with me as a renal patient. These are the things that other people can't really communicate and you don't actually know. But if you encourage patients to you know what, this is new, this is gonna continue to be something that, because you're living this life. Take a journal, have a diary, notice how you're feeling at different points of the day. Give them some ways to be accountable, and you will be able to then see what they're assessing, and it can help you in their plan of care and focus, because they're their own advocates, or they have someone in their life like Bobbie, who's their caregiver, but again, they're still spectating from the sidelines. So it's the small things that can actually make a difference.
So what else is going on in your life that's impacting this?
Very much so.
Which,
what do you think is a problem? You know, because it could be just that small thing, but it becomes something totally major. And at that time, I didn't think it was a problem until one symptom became something that I said to myself, let me keep assessing this and figure out what's going on. And then, okay, you know what? I'm able to get a colonoscopy. Let me find out what's going on. And go further with that. But you're not, if you don't encourage that, people don't even know that that's an option. And that's the biggest thing.
So what can clinicians do to better enhance that communication? What about patient education or, written material? What are some suggestions from your experience that would enhance some of this, and not just oral communication, but also possibly written communication or inserts or, the world's your oyster.
I have a comment about that. Before I came here to the Roundtable meeting, I was really excited about this, and my son had his 1-year kidney checkup, biopsy last week, and we were at the transplant center, and his post-transplant coordinator came in, and I told her about my being here. And I said, do you have anything that I could offer up to the committees here about what your experiences are? And she said to me, in terms of like the medication and dealing with the patient, she said, by the time they get to me, especially those patients that are coming out of centers where if they're in-center dialysis patients, the nursing staff, although very professional in doing their jobs, they think that they're being really helpful. They go and do everything for the patients there, and there's not an education point or an education type issue there to help the patients learn why they're doing certain things or to actually do things for themselves. By the time they get to her, having gotten a kidney transplant, she finds that those patients are losing their organs or they're going into rejection simply because they are telling her that they can't do it. They can't manage their medications. They don't know how to take them or when they should take them. They don't know what they're all about. So she went on a step further to say that to go and maybe have or set aside or make it mandatory that patients be educated when they do come into the centers for their dialysis. Maybe it might only be a 10-minute education session per week. But to tell them, say, look, I'm giving you this medication now, or you're to take your medication now, this is why you're taking it. Or this is how you set this up, or these are the times that you have to do it. But to educate them going forward so that by the time they do find that they're in the position to get their kidney transplant, that they are at least educated to some standpoint to know the reason why they have to do it and the fact that they do have to do it, otherwise they will lose their transplant. So in other words, she was saying there's a problem here, here's a solution that maybe you might consider adopting some measures along those lines in terms of education, with being the nurse in the in-center for dialysis being the frontline person to deal with the patient, to educate them before they get to transplant.
So thank you. In that statement that you shared, in health literacy, we talk about chunking information, giving little bits of information at a time, 2 to 3 key points, and then building upon that. So she's, speaking to key principles of health literacy. So we need to operationalize that, I guess, a little bit more, maybe.
Yes, and it would help the patient take ownership of their particular situation and empower them to even do even more down the road. It would be better totally all the way around for them as well. So you'd be doing a service for the transplant people, the coordinators that manage it after the fact, a service for the nurses in the dialysis center, but more importantly, what this whole thing is focused on is the patient and educating the patient.
Thank you.
I'd like to add to that, thinking about not only context being king, and especially better understanding compliance and better understanding how we manage our conditions and what we can do, whether that's oral or print. We also have to look at the fact that information is a two-way street. I think Darvece is a perfect example. She's a complete outlier. Everything that she has stated puts her out of the norm of the patient track that she described earlier. And I think that that's a critical and very salient point to talk about, because from a doctor's point of view, if we're not looking at the context of our patient's life and encouraging them to record, track, and monitor that by enabling technologies, whether it's applications or physical journals or whatever, so that they can bring that information back and give it to their care provider, and their care provider can either record it or implement it into their EMR system, is so important. Because we go to our doctors, every 3-6 months sometimes, depending. And of course, we're always asked these 10 very generic questions. Well, what's happened in the past 3 months or 6 months or a year? How am I supposed to remember that? And how are you, as a care provider, supposed to be able to give me the most objective and actionable data and information based on that? It's critical that we have a better understanding of the context and lived experiences of our patients by being able to enable that kind of data capture and make it meaningful, so that both the care provider and patient can better manage their care more effectively and more efficiently in ways that really looks at what's going on in their life. If they're having dietary issues, are they having more stress? What's going on outside of being in this room, and what's outside of the medical records that we can pull up on our EMR systems.
I think that when we spoke about that too, you first mentioned better ways to encourage compliance. And at first that felt a little uncomfortable to me, but you mentioned a lot of C words. And it's interesting when you look at it from this perspective. Correlation, because we're missing the boat maybe on many things, capturing what's going on in my life, what's the context, what's the why, and all that leads to hopefully enhanced compliance, which leads to better outcomes, patient safety, and all the things that we're striving for. So it's a lot of C's.
Absolutely, and thinking about it from the point of view of the side effects issues, these other outcomes or cascading effects that could be happening because, it might be because of a drug interaction, it may be because, we suffered a death in the family, and so because of that, our stress levels and our grief are exceptionally high, and those have, direct effects on the outcomes of how we deal with our symptoms and our conditions. And so being able to, as a care provider, to be able to pull that information up and have an honest, healthy, and good conversation with the care provider, or the patient I should say, and be able to look at, well, what's going on in your life? Why did this happen? Your stress levels seem really high. You've decreased using your Fitbit for going and working out. What's been going on? We're seeing these other side effects. Let's see what we can do about that. And let's get a better understanding of you as a person and your situation in your life and your lifestyle, and how we can better focus your treatments.
So individualizing the patient education to provide person-centered care, essentially, that meets your needs. Yeah. Darvece?
I think that a major thing that should be implemented is taking our roles and responsibilities as well as our job titles seriously in terms of having the patient being able to identify you based on that in your delivery, in your customer service, in your feedback, in your implementation. When people, especially from a patient perspective, generally see your title, they see doctor, they see pharmacist, they see nurse. There are expectations that come with that title. And the human factor needs to be and has to be realizing that before you interact with that patient, they already have an expectation in their mind as to what you're going to deliver, how effective you're going to be because of that title. You are a doctor, and so I can ask you anything. You are a nurse, and so I'm more comfortable bringing certain things to light. You are a pharmacist, and so whatever's on this paper or whatever may not be on this paper, I can come to you and ask you. And so when you operate primarily from that standpoint, you have to make sure that that's what you're giving off voluntarily. So when that person comes and picks up the prescription from you and you say, hey, listen, this is the literature that comes with it, but here's also my card, the number. Please ask me anything and know that we have resources here for you, even though it may not be printed on here what you may be experiencing, because patients don't know that that's an option. They think, oh, these are the side effects. These are the adverse reactions. Both of those mean these are bad things that are happening. And so what about when they have something that they're experiencing, it's not on here? Well, maybe that's just me. Or maybe that's this. Maybe it's the weather. Maybe it's all of these things. I know, for example, an issue that I kept running into was that because when I first started this journey, I was 34 and now I'm 36. Well, I still ovulate. I still have a menstrual cycle. So here it is. I'm on all these gerontological medications, and I'm taking these journals. I've always took journals, and now even more so, I'm keen on why I feel this way on these days, why certain effects are happening, aren't happening. And I'm going back. I'm from Chicago. I've worked everywhere at the major institutions, so I personally know my doctors, my PharmDs, my nurses. And I'm trying to figure things out, and at the top medical hospitals in the world, and we don't know, Dee. We don't really hear much about that, because why? Everybody else is 65 plus. They're not going through the issues that you're going through, so we don't have a research database for that. And I'm left to fend for myself, so I had to wean myself off of 12 medications, because your research isn't even based on someone like me. So if I'm asking for a 24-hour urine collection because I'm trying to compare my creatinine and this and that, even though I'm kidney failure, well, we don't really do that. You're on dialysis, we kind of keep you there till you get a kidney. No, like, how am I going to know if I'm improving? How am I going to know if this iron is being effective other than my H&As? Well, we only take those every, 3 months or 6 weeks. Kind of depends. What? Well, I'm on a fluid restriction, but I'm taking iron 3 times a week, and I'm taking calcium. Who's monitoring my parathyroid levels? Well, Dee, okay, so if I have my thyroid removed, then maybe. But if I take too many binders, that could happen. It's one of those things. So then I develop a closer relationship with my PharmD on my own. Okay, saying these are my issues, this is what's going on. And now, after 19 months with these treatments, I just got my first menstrual cycle. No one could explain what was happening with my body and why. But my body was just in starvation mode. And once I took away all the medications and focused on a natural diet and became vegetarian, increased my activity, increased my fluid consumption, everything came back in a different way, and that's progress. And now I'm in 4 research studies because of that, and they want to know more. But what about the people that can't communicate that? Where are they? And when I was founding my organization, that's what I resourced. Where are the moms? I have an 8-year-old daughter. She was 6 when it started. She doesn't even know I go to dialysis. What's that? It's too much. But you're fighting for your life while trying to be compliant, while trying to get a transplant, while monitoring everything that's going on. No 2 days are the same. But if someone holds a patient responsible, just to any avail, it would make a vast world of difference.
Or at least start with a partnership, maybe, right?
Really, yeah.
Start there and then build upon that over time.
Yeah, it does.
And develop that relationship.
It's major. And even the senior citizens, they look forward to picking up their medication from the local Walgreens or CVS just to see John or Donna, who's off, who's on, I'm feeling this way. So just don't take your position lightly. Realize that that's the moment each and every time.
I have something to add to what she just said. One of the things that I learned along the way to help my son, was I was at the Kidney Health Initiative meeting a year or so ago in Baltimore, and one of the speakers there mentioned a book. It was called The Patient Will See You Now, and it talked really effectively in that book on how to communicate with your doctor, what expectations, how to set expectations, what to expect back from your doctor. And I learned a lot from that, and I took those practices, the things that I learned out of that book, to the meetings with the doctors, a lot of the doctors, and meetings that we had with the physicians, and applied those same principles, which has actually gotten me here today. And I strongly suggest, if you can pick up a copy of it, I picked it up online very inexpensively, but it was well worth reading in terms of communicating and trying to get your point across and getting people to do what you want them to do. I enjoyed that book, so it's worth looking into.
Thank you for that. So we have 5 minutes left, I believe. So if you could, as Ruth sometimes says, had a magic wand, or if you had a wish, what's one innovative idea, even if you don't even think it could be done, but what would one innovative solution be to enhance medication communication? Darvece, you want to start maybe? Or whoever wants to start.
What I would like to do, I'd like to touch on the legislative aspect of things for right now. My son, he is on Medicare, and after 36 months, because he's so young, he's only 26 years old, that insurance coverage or protection is going to vacate him. It's going to leave. And he has to be on immunosuppressant medications the rest of his life. And I am very concerned. I know that time clock is ticking right now, that he is going to have access to the medications, that they're going to be affordable, and that he can secure insurance coverage in the future to cover that, to meet those needs. So I know that there is some legislation trying to work its way through Congress or whatever now, but that is a primary concern relative to medications. And I think the other thing that would solve everything is if they could come out with an artificial kidney, implantable kidney, and we wouldn't have this problem. We wouldn't be having a discussion about medications at all. But that is a big hope and glimmer for me in the future. I really hope that comes out.
Thank you.
Mine would be assisting with the different fundamental aspects in terms of funding for medication and assistance with medications. Those that know. So each drug company has different options for attaining medications, assistance with, but a lot of people don't actually know that and feel intimidated when it comes to actually implementing that. But if we as clinicians and those that have the positions would encourage that more, it would greatly help, because again, I'm looking forward to my transplant, but I'm not looking forward to everything that comes with that element of it. And so right now, if I'm on medications that are getting delivered to me once a month because I'm willing to be in a trial, or because I'm willing to get into some safety net program that can help me and have these resources, that makes everything better, for me in my life, and it would help other people more so.
As a designer, of course, I want to talk about technology development, but I'll take a step back from that. For me, I think one of the most fundamental, simple innovations would just be a reframe of perspective from care providers and a reframe of perspective for their patients, and thinking about these long-term chronic conditions. 10 years on immunosuppressants, the rest of my life will be on immunosuppressants. I totally understand what Bobbie's son is going through from a different perspective. And thinking about it from the care provider that, this diagnosis means a drastic change in your life, and it's a journey, and it's a constant experience that has to be navigated. And to think about it from the point of view of not these truncated little instances of you showing up in my clinic or my office or hospital room or whatever, and thinking about it that, this is going to be a process, and it's going to be a journey, and better understanding the perspective of what's going to go on in the long term completely changes the mindset and the workaround as to how we think about providing care for our patients. Sure. Yeah, so I kind of mentioned...
That's your area of expertise.
Yeah, a little bit earlier, but being a patient with psoriasis, something that I've been working on for about the past couple of years is how do we enable these communications with our patients? Mobile healthcare is becoming more and more of a thing, and I don't mean like telemedicine where, I can Skype in my doctor, but while that's important, but looking at this empowerment of the patient, empowering the sense of communication where both care provider and patient can better understand the context of their life. I mentioned a little bit earlier, and that's really, where I think innovation is being driven. It's how can we better enable and empower our patients to better understand, better communicate, and have better control of their lived experiences, and make them feel empowered that they can do something meaningful in their life, and that this isn't just a terrifying situation that they have to suffer through, that they are human beings. And even if it's as simple as designing applications that allow you to just track your metabolism or your food diary or your sleep, your stress levels, and being able to connect that back to your doctor's electronic medical records so that whenever you come back, it's no longer those 10 generic questions with those 10 generic responses. It's very specific answers and very specific questions about instances and situations in your patient's life, so you can better say, maybe we need to make a pivot. Maybe this medication actually isn't working. Maybe we should try something new. And being able to look at care providing as a relationship and a two-way street is so important, especially when it comes to dealing with chronic conditions. It's not the, I'm the doctor, my word is law. It's we're in this together.
I'd like to touch on the technology aspect as well that he just mentioned. I feel that it is vitally important to get a centralization of medical records, as particularly prescription medications. My son is right now on probably 15 different medications a day to manage going forward, the blood pressure and all the other complications. And there are emergency situations that come up that if you travel, if you go to another facility, there's no way that you can write those on a medical alert ID. And he's not inclined at his young age to even carry something like that with him to identify that. And in Pittsburgh, where I live, there's two medical systems. They do not communicate with one another. They're fighting against one another, so they don't share medical records, and it's very difficult. I do think that some work is definitely needed in this area, especially related to the prescription medications that patients take, that there has to be some sort of centralized network going forward that no matter where you are, that information is accessible.
Thank you very much. Are we ready for questions? We're a little over. Okay, great. Well, thank you so much, really, for sharing your experiences, for taking time out of your day, and for the meaningful conversation. I'm sure we all have taken little bits and pieces from each of your stories. We're going to open this up now to questions, and we'd like to take the roundtable member questions first, if there are any. Do you want to step up to the mic?